Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hi, David Kaufman. We're back with episode 6 of Unraveled.
And I am Eileen Ruhoy, his co-host.
No, conversationalists,
That's right, we're
co-conversationalists.
co-conversationalists.
So today we're going to dive into infection. We're going to try to divide it up into bacterial and viral. That's a fairly loose and somewhat crude division, but we got to start somewhere.
Can you just remind me of the taxonomy again? I was thinking about this when I was driving here today. Right, so bacteria and viruses, those are types of microorganisms, groups of microorganisms. Right. And then the name is the species of the particular organism, right? Okay.
And there's further divisions, parasites and...
Okay, I just wanted to make sure that I use the right lingo. I don't want to refer to them incorrectly.
I'm going to try to avoid some of the lingo.
Yeah, maybe that's the best.
So, full disclosure, I am very biased towards infection, meaning I look for infection all the time. I think it is absolutely crucial to understanding what's going on with our patients. Certainly I'm biased because of my early career doing HIV medicine, but I think it's very relevant to these patients. And if some of you have seen me speak at other meetings, I think it's all about infection. And if you don't find it the first time, just go back and look again, okay? And it's going to be a little bit of a difficult conversation because I want to discuss bacterial infection, but I'm not sure we'll have time to go into how you work it up, or certainly not how you treat it, et cetera, et cetera. But I think it's important to get started.
Yeah, I agree. I mean, this is obviously a very large topic, and at some point we have to devote to specific bacterial infections because of what we know about them today and how they affect our patient population. But I do think it's important to just sort of address the idea that an infection, once resolved, doesn't ever really, or once you think it's resolved, doesn't ever really resolve for many people. And there's lots of post-infectious problems that is largely what we deal with and what we try to treat from various perspectives and points of view.
So I've given a few talks on this. The most recent was at the Mast Cell meeting in June in New York, and then the previous one 3 years earlier in Boulder. And I would like to see if we can somehow figure out to do our show notes and put some of the slides on, because I think it would be very, very helpful for people.
How hard can show notes be?
I know, but look at us.
Exactly, look at us.
So I'm just going to start with a few basics, okay? Again, these are things that I'm personally very fascinated by. For me, it's all about infection and evolution. The two are intimately entwined with each other, or entangled, to use a physics term. Make my son happy. So about 1.5 billion years ago, one might say we cells that became human, or part of human beings, had our first infection, which was mitochondria, organisms that were free living bacteria. They were, we don't know what they were called then, obviously, but we call them mitochondria, and they got inside eukaryocytes, the cells that became human beings, and now we cannot live without them. If we don't have mitochondria that function, we're dead, period.
I remember learning that in med school, and that was like one of those moments that I thought, oh, this is just too crazy to be true. But it really is true.
Mind-boggling.
Right?
Okay.
Right, there's a symbiotic relationship. And I think that's just amazing. And I think about, what that means for all of mankind in general. Exactly. Like there's so much applicability to symbiosis, but it is incredible that mitochondria just used to be these organisms that lived on their own. We incorporated them into our cells. We give them nutrients and ways to survive, and in return, they give us energy. And that, of course, is the basic teaching of mitochondria, the energy powerhouses of the cell.
Right.
But now we know so much more about mitochondria, which of course is not the topic for today. But it is such an amazing
it is part of the
origin
topic for
story.
Today. I mean, it's so fascinating. And we wouldn't be here without that singular event 1.5 billion years ago. And part of the reason I bring it up is most of us, I venture to say, every person. If you say, tell me what comes into your mind right away if I say the word infection, they're going to say some version of bad. Not good to get an infection. But I would argue that's absolutely wrong, that mitochondria are an example of infection that have made us who we are today as we sit here. Microbiome is an infection. Many trillions of organisms live in our colon. We would not be here without them. It turns out there are microbes in our lungs, in our pancreas, in our blood.
On our skin.
We are not sterile. You and I were taught we were sterile, except for our skin and gastrointestinal tract. Mm-hmm. Absolutely not true. And we live in harmony with all these different microbes. So I could go on in that, but I just want to emphasize that infection is not bad. Okay, there are bad infections, and they have acute sequela and chronic sequela, and unrelated to the infection itself sequela. But we need to remember that without these microbes, we wouldn't be here. So, in defense of microbes and bugs.
But I mean, there are certain, and correct me if I'm wrong, but there are certain microorganisms that humans were never necessarily meant to come in contact with, right? Which is one of the problems that we're seeing in more recent decades, which is as we continue to tear down, more forested lands and lands that were always naive to human exposure, we are becoming more and more vulnerable to organisms that have been present for a very long time, but were never in contact with humans. So the human body was never we were never challenged by these particular microbes.
I would say yes and no. I think a great example of what you're talking about, which is going to take us down another road, so we got to be careful, is COVID. Mm-hmm. All right. The reason COVID was a catastrophe is we were never exposed to it. So you had 8 billion. Mm-hmm. Is that how many people there are? 8 billion? 8 billion people without antibodies to this bug.
Right.
Unheard of. Okay. And that's what we saw what happened. So similarly, you're right. As the environmental catastrophe progresses and the permafrost melts, there are bacteria and viruses that are being liberated and literally reactivating, and we have never seen them in immunologic terms, and so we can't mount an immediate response, and that's going to put us at great risk. Mm-hmm. I would flip that a little bit. I said yes and no for a reason, and again, we're going to get a little diverted here. There are some hypotheses out there, the hygiene hypothesis and the good friend hypothesis, which basically say because in the more developed so-called first world, because our hygiene is so good, we have those wonderful things called bathrooms and running water, and in America certainly this thing about staying clean and wiping everything and don't play outside in the dirt. We have not. We may well have untrained or less than adequately trained our immune system. And that's probably another topic, although incredibly fascinating topic. The rise of autoimmune disease because our immune system has not been conditioned by having organisms that usually helped us develop tolerance.
Do you subscribe to that? Because I realize that as a first world country, we're considered a lot more sanitary than other countries, but we're not exactly sanitary, right? So we're not sterile, I should say. We don't grow up in sterile environments. We still are challenged by the people we come in contact with, by the food that we eat, by where we decide to play, where we decide to vacation within our homes. I mean, I think that we still are exposed, no?
No, of course we are. There's microbes, bacteria, viruses
so you're saying
everywhere.
Not enough?
Well, I'm saying that our intensity and types of exposures have changed, particularly in the gastrointestinal tract. 70% of our immune competence, our immune cells, are in the gastrointestinal tract, 70%. In the course of evolution, there's a reason for that, and part of what happens with the GI tract is that exposure to organisms appears to train or help the T cells and T regulatory cells to develop tolerance, or to, I want to say learn, but that's the wrong word, evolve tolerance, meaning tolerance of ourselves.
Right.
And so that prevents autoimmune disease. And now if you look at the rise of autoimmune disease, and there's this great slide I had in this talk, which shows you the steep rise in all of the classic autoimmune diseases. And on the side, I put down long COVID and ME/CFS and POTS, etc. But the typical ones, Sjogren's and lupus and RA, correlates or follows the decline in infection and the increase in, quote, hygiene. It's really fascinating. I'm sure it's not the only answer, but it's...
No, that is interesting to me, actually, because those common autoimmune diseases that you just named are also connective tissue disorders, right? And yet we see a rise in what we've been referring to as hypermobility kind of thing. But,
right. And you know better than me, but it certainly could also be exposure to all the endless toxins that we pour into our environment, our food and our water and the soil.
I was actually going to say that, trying not to say too much about it, because of course our topic today is really about bacterial infection. But along with all of that, there has been a tremendous rise in the level of toxicants and contaminants in our environment.
And it goes along with that. The curves also match
so it's exposure,
that.
I guess. I guess we're talking about exposure in general. Right? Our exposures have increased.
Right. I don't want to say it's just that, but I think it's a very important concept. There's a great book that I talk about all the time called Epidemic of Absence, which just goes into this whole idea so beautifully with tons of literature and tons of facts and examples and stuff. I would recommend that to everybody, that book.
Yeah, I remember when my daughter was young, actually, there were some parents in my Mommy and Me groups who were saying that that they were reading that if kids were put in daycare at a very young age and were exposed to other germs from other kids, there was a lower incidence of leukemia. I never actually looked it up to know if that's true or not, but it's sort of along the same thought process.
Yeah, same idea. Okay, so let me get us started here. There's many different kinds of infections. We're going to talk about bacteria. We can broadly break it down to acute infections and chronic infections. I'm not really going to spend much time on, or any time on acute infections, but just so our viewers, listeners, whatever we're doing here, understand what I mean. You can have an acute strep throat, and then you get better. You can have bacterial bronchitis from a bacteria, let's say mycoplasma. You can have a staphylococcal infection of a cut or an injury. And in most cases, with or without antibiotics, you'll get better, and that's the end of the story. Okay? So we're going to sort of leave those on the side with the caveat that the chronic infections are often caused by the same bugs. Okay.
Is it a reactivation? Is it that it never truly resolved in terms of its acute infectious process?
I think it depends on the infection. So we can further divide this. Again, this is the way I look at it. I'm sure there are other ways that people divide it into those infections that are easily killed either by antibiotics and our immune system. And I would add that we really need an intact immune system, not just antibiotics, to get rid of these infections. And then there are those infections that often are intracellular and have evolved, this is all about evolution, have evolved a way to hide from our immune system, to shield themselves, to cloak themselves in ways that make the immune system blind to their existence, and so they can happily live in a cell and decide, in quotes, decide that, okay, the coast looks clear, I'm going to break out of this cell and replicate. And so examples of that would be tuberculosis is the classic example. I grew up in New York. I took the subway. I'm on the subway in 1969, let's say, or 70. Some guy or some woman coughs in my face. I get infected with a tubercle, which is TB, Mycobacterium tuberculosis. I don't get sick. Nothing happens to me. My immune system, I'm young then, is very healthy. It goes after those tubercles and walls them off in my lungs into a little calcified cavity, and I'm fine. 50 years later, I get COVID, or I get steroids, or I get cancer, or I get immune suppressant, or I just get old and my immune system declines, and all of a sudden I have active TB. That is the same bug that was acquired 50 years earlier. Right. It's a mind-boggling concept, but it repeats over and over with many different organisms.
So it just doesn't die. It just remains dormant.
It remains dormant. Whether you want to say dormant, latent, inactive, persister, and that's true of many intracellular organisms. So some of the classic ones obviously are TB. not doing viral, so I won't go into that. So TB, mycoplasma pneumonia can do that. Chlamydia, respiratory chlamydia pneumoniae, not genital chlamydia,
Right.
can all be intracellular and can hide from the immune system. And so often antibiotics will not get rid of those infections. The immune system can take over, but if there's a failure or a loss of some competence, then that infection can become relevant.
Does that apply to the tick-borne ones as well?
Right. So the big new one, controversial as always, anything related to Lyme disease these days is very controversial, but it's pretty clear that Borrelia, the cause of Lyme, a bacteria called Borrelia, it's a spirochete is the fancy name, can be intracellular and can basically cloak itself and hide from the immune system and then reactivate. It's not well accepted by mainstream medicine, but those of us who take care of a lot of patients, we just see it all the time. And in the last few years, there's been a lot of research to help support that by describing what we now call persister organisms. That term is used mostly for Lyme, including the discovery that perhaps the reason that in 5+% of people the treatment of Lyme doesn't work, they keep getting sick, is because the conventional antibiotics that we use don't kill persister bugs. That's been shown in laboratories at Stanford and Northwestern and Hopkins, I think. And conversely, they discovered off-the-shelf molecules that are not considered antibiotics that do kill persister drugs. So now many of us who treat Lyme disease will use both kinds of drugs. So your classic antibiotics, rifampin and amoxicillin, Augmentin, Bactrim, doxycycline, clarithromycin, those will work against actively replicating Borrelia in the blood, but they're not going to work if you end up with persister organisms in your cells. And so those antibiotics probably wipe out, let's say, I'm going to make up numbers here, 95% of the replicating bugs, but the other 5% are sitting inside the cell just watching the action, so to speak. And they're waiting. They're there. And when you stop using the antibiotics, they can come back out. And that's why so many patients will say, I feel great when I take the antibiotics. I'm all better. The doctor thinks they're all better. 3 months later, they come back. Their symptoms are all back.
So what do you use for the persister organisms?
All right, well, this is going to take us. So the drugs that were discovered in the laboratory and that many of us are using one is disulfiram, fondly known as antabuse, given to alcoholics to prevent them from drinking, help them not to drink. Turns out it can kill persister bugs. Methylene blue, which is used in emergency rooms to treat carbon monoxide poisoning and certain other kinds of liver problems, is also effective at killing persister bugs, excuse me. And so some of us will alternate back and forth. I mean, this is sort of an evolving picture. We're not sure how to do this, or at least I'm not sure. But it explains a lot. And I've seen patients get better when you use these drugs.
Is there a way to identify histologically these persister organisms? If we were to take tissue samples and look at, you can see cellular, structures under a microscope.
I don't know. I don't know how you would do that.
Well, you can stain for organisms, right?
Right.
So, and you can see cellular structures under a microscope.
So there is a lab, Bob Mazzani's lab, where he's doing something like that. But I believe, and it would be great to get Bob to talk about this, I believe
we should invite him.
That his fish testing, that's what it's called, FISH, it's a fluorescent stain, has an RNA probe, so it seeks out, the probe is specific to the organism, so Borrelia has one and Babesia has a different one. And so they're like guided missiles with fish stain, okay? And then he sends the pictures, and you can see the fluorescent antibody, the fluorescent stain, but it seems to me it's on the outside of the cell. So I'd have to ask him that question. I don't know.
Well, these are bacteria, cellular they're cells, so you can see the outside of the cell, I would imagine. Right.
The question is, are you able to see it inside the cell? If it's stained, I don't know the stain will get into the cell, so it might be hard. I don't know the answer.
That would be interesting, right? To do a study like that. So is this so? And I understand everything you're saying. I'm just, because you can't identify them histologically. Is this like theoretical? And just because you add disulfiram, for example, or methylene blue, and it seems to work and help patients, that we now believe that this to be the case for these chronic infections?
I'm smiling because I wasn't sure we were going to go down this road, but
we don't have to.
Let's do it. We're on the road. It's a very, very bumpy road and a lot of potholes.
It's a controversial road,
yeah,
right?
It is very controversial.
And I only ask honestly, I do believe in chronic infections. I see it as an immune-mediated problem, right? So this is a different perspective of it. We both see a lot of patients with lots of chronic infections.
Right.
And I see it as a post-infectious sequelae is really what I refer to it as, only because I see it as an immune problem. And I recognize that there are many other doctors that see it as just a persistent infection problem.
I agree with you 100%. I don't want to separate it. That's one way I started, or hoped I said in the beginning. That, this is not just about infection. It's about how our immune system copes with that infection on the one hand, and how that infection injures and harms our immune system so that other things can happen.
Do these persistent organisms, do they continuously provoke the mast cells? Does this become where...
Well, certainly for Borrelia, for Lyme, there's good evidence that it can cause or provoke mast cell activation, right?
Right.
And if you think about it, mast cells are part of our immune system.
Right.
Ancient part. And they are both defensive and offensive. And they are, as we mentioned, they're very dense in environmental interfaces, meaning skin, lungs, gastrointestinal tract, and also around blood and nerves. And Borrelia can circulate in the blood, and it can also hide inside cells and be in locations that will kick off an immune response and a mast cell response. So yeah, I think they're very much related.
Yeah, I read about how they burrow into tissues very easily.
Right.
So they can have this silent provocation of innate and adaptive immunity.
Exactly.
And you can't necessarily see them, so that you could do all the blood tests you want, and it won't be positive because they're hiding in tissues.
Right. I mean, the challenge with, I prefer the term tick-borne infection, but I'll just say Lyme, is our diagnostic techniques stink. They're just not very good. We can do antibody testing, but as I think people understand, that doesn't mean you have the infection at that moment necessarily. It means you may have had it in the past, and even there it's not definitive because antibody testing can cross-react. So a classic example is for Lyme, for Borrelia, the IgM test can cross-react with EBV, Epstein-Barr virus. So you have to be pretty careful and cautious about making these diagnoses. The best way to make any of these infection diagnoses is with direct testing, which means fish testing, PCR under the microscope, or ideally culture.
Right,
okay?
Of tissue.
Of tissue.
Yeah, no, for sure.
Culture of tissue or culture of blood to grow the organism.
Right.
Because then you have it.
Right,
As long as you trust your lab, if you can do any of those four, that's gold standard confirmation.
No, in the past few weeks, I would say there's been a handful of times that a physician has reached out to me about a mutual patient where, in fact, just yesterday I spoke to another doctor who wasn't my patient, but had a patient who had actually passed away in a hospital, got up from the hospital bed, young woman, fell to the floor, and was dead, basically. And they had sent some brain and cord tissue to a biobank that apparently exists for tick-borne infection studies. I'm not that familiar with it, and they found Babesia. So he was telling me about this one case, and it just sort of sparked me. I knew we were going to be talking about this today, so I had all these thoughts in my head about what are we missing here, right? How many patients are we missing the boat on because we don't have great diagnostic capabilities, and obviously we don't want to wait for it to be post-mortem. Right, that's morbid.
Yeah, no, I think most of us who are working in the tick-borne infection world think that we're missing hundreds of thousands of cases.
Right.
I'll give an example. There's another bug, bacteria called Bartonella, which is part of the tick-borne disease constellation. However, Bartonella is also transmitted by dogs and cats and horses and skunks and possums.
Which is why, by the way, why our last conversation about the history taking
You're right, exactly.
is so important.
Exactly.
But go ahead.
All right. And then the vector is also lice and fleas and mites. Okay. So it's much more widespread potentially around the world than Borrelia, which is also around the world. So when I do antibody testing, or IFA is a term of the kind of testing at a lab which I think is great, called Galaxy Diagnostics, I've complained to Galaxy that everybody's positive. Everybody comes back, 1 to 128, 1 to 64, and 256. How could that be?
Yeah.
And their answer is, that's the test. It's coming back positive. And my conclusion is this is an enormously widespread bacteria, which we evolved with, as always, and we have ways to cope with it and keep it controlled with our immune system. But for some people, either because of the size of the inoculum, the burden of infection they're exposed to, or because of problems with their immune system, or because of subsequent problems that harm their immune system, they get incredibly sick. And it's not easy diagnosis to make. Yeah, I think you and I, the patient, doctors like us, we're dealing with the tip of the iceberg. It's easy to diagnose strep throat. It's easy to diagnose sepsis. You come into the hospital with no blood pressure and you're near dead, and you draw a blood culture and it comes back with staph. It's obvious. It's staph sepsis. Those are the easy cases, in a sense,
Right. So doing the resistance and sensitivity testing doesn't necessarily clear these infections because of these persistent organisms.
Well, yes, but worse than that, we're not even able to do resistance and sensitivity testing for Bartonella.
Oh, right.
It's like a nightmare.
Jeez.
Okay. And that's a huge problem. It's part of the reason that we struggle to treat this. I mean, I'm sure you've heard me talk about it. I have patients I've been treating for years and years and years. Other patients get better. Mm-hmm. Other patients don't.
And it's about the size of the inoculum.
I believe, along with their immune system.
Right.
Yeah.
And so do you work on, when you see these patients and treat them from an infectious perspective, do you also do a workup on their immune system to sort of see where you can support?
I do. So my initial workup when I have a brand new patient come in is a ridiculously large blood draw. And I warn the patients, like 30, 35 tubes. The phlebotomists hate me. The patients hate me. And among other things, I'm doing an immunologic workup that's basically IgG subclasses. Those are our major antibodies. IgM levels, which are our initial antibody that we make. IgA, which is the antibody that lines our gastrointestinal tract and nasal mucosa and stuff. And then T-cell subsets. So there's way more you could do, but that's my initial, all right? And you'd be amazed how many patients come back with some abnormalities or a lot of abnormalities, having been to 15 or 20 other doctors. And then I do a fairly broad shotgun approach to infection, which is looking for antibodies to strep, mycoplasma, chlamydia, and then especially the herpes family of viruses, which we'll talk about probably in the next episode. And then pursue based on that.
Right.
So, and to explain why I do that, if I get a strep back, let's say a patient comes in with an MECFS type picture, complaining of brain fog and some neuropsych symptoms, okay? And I do those labs and I get a strep antibody test back that's high. It's called ASO, or anti-streptolysin, and also DNase. The first question to ask, history, okay, is, have you had a strep throat? Mm-hmm. And if so, when? And if they say, oh my God, I haven't had a strep throat for 4 years, that makes this a very, very important finding, because unlike some other IgG antibodies, say to measles, mumps, rubella, strep antibodies not supposed to hang around. I think it's generally considered maybe 3 to 6 months, and then it's gone. Mm-hmm. Which is why you can keep getting strep throats. Okay, right. So if this patient hasn't had a strep throat for 4 years and has a high titer, a high IgG, I believe that likely we're looking at somebody who's either colonized or has an occult infection, and that's relevant because of the sequelae that you alluded to. Strep is notorious, infamous for causing autoimmune disease.
Absolutely.
It is the model I mean, in my mind anyhow, the model bacterial infection that leads to autoimmune disease. It causes rheumatic fever and rheumatic heart disease, seizure disorder, whose name I just forgot.
Pandas.
Pandas and PANS, and a glomerulonephritis. So it's hugely important because that may be what is causing or contributing to this ME/CFS picture, which is just a label that's describing, that says the person has these symptoms but doesn't tell me why, and that's what we're trying to find out.
Right. I mean, if you look through the literature on ME/CFS and infection, there's actually quite a number of studies over the years that have shown at least a correlation, if not causation. And I think it's a real important area of research that should be more money should go towards it, because we need to establish that connection, because I think the sooner we can suspect that this might be a concern, the earlier we can treat and the better the patients are. And I think, certainly as a neurologist, when I'm thinking about, are any of these affecting the central nervous system, for example, I mean, that's a whole other ball of wax, right? Diagnostically, it's hard even to find things on the blood. In fact, I recently learned that some institutions, I do LPs, and some labs won't even check for Lyme on CSF if they're not positive on blood work, which is, maybe there's some research to support that if it wouldn't have.
I don't know if there is, and I would question it. It doesn't make sense if you think about it.
Right, it doesn't make sense at all, because if...
In fact, I'll give you an example.
Okay, love examples.
So I have this patient I've taken care of for 9 years. She's a vet meaning veterinarian. She's still sick. Her blood, she's a standing diagnosis of Bartonella, treated all this time I've been treating her, okay? Her blood cultures, or they're not really called cultures. When Galaxy does this, they do what's called a digital drop PCR and the IFA. I don't even bother with the IFA because obviously I know what's wrong. I mean, I know she'll have antibodies. Her blood will be negative, and she's had 2 spinal taps that were positive.
Wow.
All right, and she has a 3rd one cooking right now. Okay.
That's a great example. Yeah.
So you can't assume that, and I'd love to see the research they use to support that.
Right, I would too.
Yeah.
I doubt there is any. I think they just sort of try to decide where they're going to, put their money in terms of testing. So
to get back to something you just said about ME/CFS and infection, so it's pretty well accepted by even mainstream and NIH that roughly 2/3 of patients who present with ME/CFS, their illness began with infection. Right,
but it's not always the same infection.
No,
and I think that's
not.
important.
It's not. It's most often EBV and mono, EBV, which can cause mono, but it can be mycoplasma, it can be chlamydia, which are intracellular and hide from the immune system, and it can be other viruses as well. All right, and I think one of the things we're getting a little off the bacterial topic here, but that's okay. One of the things I think that's waking up the academic world here to the reality of ME/CFS is that in COVID, we now see long COVID. Well, sorry, but duh. You get this acute viral infection, and of course we're going to see post-viral infectious people who have what amounts to long COVID, which is really another name for ME/CFS.
Right.
So the parallels are striking, and hopefully we'll learn this time.
Well, there is a lot of research going to obviously post-COVID, but we can talk about viruses in the next time.
Right. Anyhow, so I look for bacteria.
Right.
And you reminded me that I should have started by saying I do that initially with history. So it's all about history, and hopefully we will say this over and over and over again. And it's not only the first history you take, it's the 3rd history.
Right, because patients don't always remember every infection that they had. I mean, when they were 11.
Right. So I go through it pretty rigorously, like literally year by year, starting with pregnancy and delivery. And then I break up childhood years and stuff. And I'm not looking necessarily only for a history of infection, although if a patient tells me as a kid they had endless ear infections and throat infections, I'm already going to be suspicious of immune problems, mast cell activation, possible pandas, PANS, all that stuff. It's all kind of percolating at the same time. But I'm also going to want to know what their exposure history has been like. So, and particularly for tick-borne disease, that's a separate category of questions. Not have you, the history isn't, have you ever had a tick bite or a tick attachment, and then I'm done. that's not the history. You asked that, but that's not where you stop.
Right.
Have you gone camping, hiking, played in the grass? Where did you grow up? Did you grow up in Michigan, Wisconsin, New England, California? Did you spend a lot of time in the woods? Did you ride horses? Did your pets, do you have dogs and cat pets? Was your cat indoor, outdoor? Was there ever fleas? And all of that is to assess risk for infection.
Travel.
Oh,
Right.
of course, travel.
Yeah, absolutely. I mean, a lot of diarrheal illnesses, for example.
Right.
So the enteroviruses are also, they've also been implicated. Oh,
Right.
those are
Major
viruses, sorry.
association with ME/CFS. Right.
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 So yeah, so I agree that the history is where really it all starts, right? To understand their exposure history,
Right.
their risk of infection, their vulnerability of infectious processes, just based on where they've been, what they've done,
Right.
who they are.
So to take it a little further, and in doing the testing, I'll give some concrete examples. So I'll do the mycoplasma organ pneumonia testing, which is IgG and IgM. We don't have a PCR unless you have stuff from the lung, that you literally get from a bronchoscopy.
Right.
So we're dependent on antibodies, which is true for almost everything in medicine and infection. There's only some exceptions. I'll have a new patient come in who gives me no history of infection and hasn't had any recent infection, no cough, no fever, no runny nose, nothing, okay? They're miserable from their illness while they're here, but not overtly from infection. And their mycoplasma IgM will come back 3 times greater than normal. Well, that's not kosher. You're not allowed to do that, okay? You can't have a mycoplasma IgM and just say, well, that just means you had infection once. That's just not...
Not IgM, though.
Well, that's what I'm trying to say.
Yeah.
So you can't ignore it. So for me,
I see that a lot, by the way. I'm glad that you
I
brought
know,
up that
it's
example. I see
huge.
IgM from mycoplasma more often than I would have ever imagined I would in this patient population. And I've actually asked some infectious disease docs that I've worked with, and they've just basically said molecular mimicry is their best explanation.
Right.
And I obviously just don't buy it.
Yeah, I don't buy it at all.
Yeah.
I mean, there's these bugs, mycoplasma, chlamydia, and some of the others. The other name that's used in their books with the title of this are stealth infections, meaning they hide from the immune system. They hide from our usual approaches to management. And so those patients, I will, with anxiety, put them on antibiotics because I don't know what else to do.
Right.
And I do believe that mycoplasma chronic persister stealth infection is causing some of or much of their problems. And there's lots of literature to support the role of these infections causing autoimmune illness. So it's not a surprise that patient with the IgM also just happens to have POTS and mast cell activation syndrome.
Absolutely.
I mean, it's all connected.
It is all connected, and we say that all the time for sure. But it's also, it's why I like working with you, because I don't know antibiotics, certainly not the way you know antibiotics, and that's why I look at it as sort of, okay, how can I work with the immune system to better protect them from this clearly chronic persistent infection? But most patients by the time they come to me have already been on lots of antibiotics and are still on them. And they definitely report feeling better on them, but they can't come off of them.
Right.
Because they come off, they relapse, they flare, they feel horrible.
It's very, very
but
frustrating.
sometimes I just struggle with, you've been on IV antibiotics for 3, 4, 5 years. Like where does it end? Are they bound to be on IV antibiotics for the rest of their lives? I mean, what have you seen? What can a patient expect?
Right.
In terms of treatment? And I don't know if there's a great answer to that, because
there's not a great answer.
Yeah.
I use less IV antibiotics than I used to, for one thing, partly because of the risks.
Right.
And I think part of the answer to that question of that group of patients is understanding and diving into this concept of stealth, persister, latent organisms. The antibiotics are not getting to those bugs. And so when you stop, the patient has a little honeymoon period when they feel better, and then they reactivate or are released. The bugs break out.
Yeah.
Right? So I say break out of jail. So we need other drugs, but more importantly to me, we need ways to enhance, turbocharge the immune system.
Yes.
And maybe that's a separate talk, and I don't pretend to have many answers. I have many ideas, but not a lot of answers. But I think that there's another slide I had in that talk where I said basically it takes 2 to tango. You have the infection, and you have the immune system. And if you don't have a competent immune system, you're not going to get rid of those infections.
Right, but it's not like most of these patients are born immunocompromised, right? They don't have common variable immune deficiency.
Correct.
So they don't have any of the classic immunodeficiency disorders that we've all learned in med school and that immunologists deal with on a regular basis. So that's what's interesting about them. There's just some deficit, some slight dysfunction of the immune system that now is just basically piled on by this chronic infection. And over time, I think they actually do develop immune deficiency.
Well, we know that infections can harm your immune system.
Right.
I mean, the classic example is HIV.
Right, exactly. And, and I have a bunch of patients, and in fact, with ME/CFS, I'm sure you've seen this too. There's a weird, I call it relapsing fever, though it's not very high fevers, right? It's like these low-grade fevers that they get, that it bumps up, it comes down, it bumps up, it comes down. And this is definitely, I see it as the immune system trying to control this infectious process.
Which keeps reactivating.
Right, exactly.
And provoking the immune system.
So I work on ways of trying to sort of fix the immune system or support it or boost it. And there's, as you know, there's very few tools that we have to do that. Yeah. And sometimes the few tools we have are actually really effective for some patients. I mean,
and sometimes those tools are taken away from us.
And that's right. Sometimes we have to fight with insurance companies.
Well,
and sometimes we have to fight with regulatory bodies and fight with other doctors and other people. But sometimes they are very, they're almost like magically beneficial to some patients. And oftentimes they're not, right? So it's a little trial and error in trying to sort of do both of how much antibiotics, what antibiotics, how do we fix the immune system, how do we help the immune system, and how do we bring this together so that the patient can get some relief and some recovery, which I think is what everyone's looking for in the end.
So for physicians that may be listening, which I hope there are a lot of at some point, one of the things I've learned or discovered through observation, not discovery like science, is that by doing these lymphocyte subsets, which looks at T cells and B cells, the number of ME/CFS patients with low to deficient B cells is remarkable. Why would that be? Now, I don't have their B cell count before they got sick, so that's an issue. Did they get sick because it was low and nobody checks it? Because there's no reason. I've never checked my B cells. There's no reason you check, okay?
Right.
Or is it a downstream result, a sequela of infection, okay? And I've seen that in tick-borne infections as well. I published a case report of 2 patients who had Borrelia and Bartonella, and they presented with IgG deficiency and CD19 B cell deficiency as well. One patient got completely better and her immune system reconstituted. I thought the other patient was getting better and her numbers were coming up, and then she relapsed. It's the patient I was referring to before, and she remains IgG deficient. So do they get sick because they start out deficient, or is the infection making them deficient in the sense of perhaps B cell exhaustion? They're working so hard you run out of steam, the B cells and the T cells.
Yeah, I mean, that's a whole other fascinating topic in my opinion. And I know that, I think we both do, but I do some genetic panels on their immune system. And while clearly a lot of these autoinflammatory syndrome, in fact, I think almost all of them are homozygous. So you need 2 variants to actually have that disorder, which is these are horrible disorders, of course, and very debilitating. But I often find one variant, which I think then just predisposes patients to what you just basically described. Their immune system, whenever there's inflammation or from infection or other exposure, there is change of expression of genes, as you know. And so when there is a particular pathogenic variant, whereas you would need 2 of these variants to actually have the disease, but you have only one, I think that if with chronic inflammation, you have overexpression of this one variant. And I don't think it happens all the time. I think it happens some of the time. And so then you basically, while you don't develop that disorder that it's associated with, you develop basically the subclinical symptoms of it, which is largely immune defect. And so I tend to do a lot of immune genetic panels to understand this individual patient's particular risk or vulnerability. And I'm finding that gives me a little bit of a proactive approach. Like, okay, we're at risk of this. And then I could be a little bit more aggressive in what I do. Again, I'm still limited in terms of the tools I have, but I could be a little more aggressive in my thought process
Right.
and what I'll throw at them, trying to protect them from what I suspect might be even a more precipitous decline at some point if we don't get this under control.
Right.
And so I think genetics play a large role in that. And I also think the interaction between the innate and the adaptive immune system is poorly addressed or poorly discussed. I think we often think about them separately, but I think, we know that there are some cells that actually overlap the systems. And I think that that's where, when you talk about B cell deficiency, lack of antibodies, the T cells they're antigen presenting cells, but the T cells also can activate mast cells and vice versa. And I think that, and even, mast cells have IgE receptors, right? So there's an overlap there between the mast cells and immunoglobulins of the E type. So I think that the intersection of the innate and adaptive immune system is somewhere we need to focus on to better understand how we could do that other, that portion of the immune support for the patients. It doesn't obviously necessarily fix the infection, especially not the persistent organisms that you talk about. But
Right.
I think that that's part of the immune system that we need to understand. And to be honest, I feel like we need more immunologists in this space,
Yes,
because
we do.
who am I talking about the immune
Definitely
system?
do.
Jeez.
Definitely do. I mean, part of the problem, again, we've alluded to this before, part of the problem is in medical school, we're pretty much taught in black and white.
Yeah.
Right? There's very few things that are discussed as a spectrum. It's either
That's
the
very
left or the
true.
right.
That's
okay?
so true.
And if you think genetics, and I think I am incredibly weak in genetics, okay? And, what you're taught, or what we were taught, is most of the time if you have only one mutation, so you're heterozygous, it doesn't mean anything. But if you think about that, is that really
It is
true?
not.
How
No.
do we know?
I'm here to tell you that it is not true.
Okay.
So I used to, has nothing to do with infection, of course, but I used to, I used to run the neuromuscular clinic at Children's Hospital, and I saw a lot of muscular dystrophy boys, Duchenne's muscular dystrophy boys, and I would always talk to the mothers who, of course, passed on the gene. And, they obviously did not have the disorder, but they were carriers. That's what we refer to as carriers. And so, invariably I would get a history of, when they were young, they were not the fastest kid, not the most athletic kid. They were the clumsiest kid, so I think carrier state actually means something.
Absolutely.
I really do. I think it does. I absolutely do. And I think depending upon what the variant that you're a carrier state of, can dictate how vulnerable you are to certain symptoms.
Right.
I think in our patient population, holding a variant of a severe autoinflammatory or autoimmune disorder, I think is very scary. Is very scary. So.
And I'll take it a step further. Obviously, these variants, heterozygous status, is common, okay? And I would venture to guess that for every heterozygous autoinflammatory gene, I don't name a gene, not NOD2 or one of those, that we find in our patients that we believe is relevant, there's probably 10,000 people out there with the exact same heterozygous variant who are completely healthy and fine. The argument I'm making and you're making is related to the spectrum idea and what I keep saying and you keep saying, which is the interconnectedness of all of this. Take that variant and stick it into a person who also has connective tissue disorder,
Exactly.
who has chronic infection,
It's the
who's
constellation.
developed POTS
That's right.
and chronic inflammation from that, and mast cell, which is multi-system, multi-organ inflammation. And all of a sudden, this supposedly benign, insignificant heterozygous variant becomes yet another player in this disaster. And it's just so important to understand that.
It is so important because it's not just one thing, right?
Right.
And I think
Not
that was
just
the name
one
of
thing.
our
It
talk.
was. Exactly.
It's not just one thing.
Right.
And again, I always say this: we suffer from silo syndrome.
Exactly.
In medicine, we really do. We are way too siloed, and it takes too much time, too much energy, and too much thought to come out of your silo and sort of see it from an aerial view, right? Which is what we really need. And I do think that a lot of this starts and ends with infection, right? It's sort of the beginning and the end of all of this because it's what triggered everything that follows.
Well, I 100% agree.
Yeah.
I mean, I'm really so biased here. I don't know how much time we have left, but I want to try to bring up a couple of more things. How are we doing on time? Oh, okay. I want to go back to history again. Okay. So you can't find an infection, or you're not sure. I can't tell you how many times I'll go over something, and then three visits later, the patient says, well, once somebody gave me doxycycline for acne, and my fever and my aches and pains went away. It's like, wait a minute. What happened when you came off? Well, it all came back.
Yeah.
I mean, I don't care about the culture and
absolutely.
antibody results, and that is telling me something. Yes, doxycycline can be anti-inflammatory,
Right.
but we're talking about somebody who's in the context of ME/CFS, long COVID, septad patient. That's significant, and you need to search for it. And I don't know how to ask some of those questions other than to say, have you ever taken antibiotics? But it's amazing how that comes out mostly as a throwaway line from the patient in certain circumstances.
The other thing that often people will say is, when I had a cold, a random cold, I felt these symptoms were better.
Right.
Right. And I think it makes me think that there is more specificity to the immune response to different organisms, right? Which we sort of know there is, but to the point where now the immune system is being activated by something else, and so there's more support for overall immune response.
Right. There's just so
not
much
explaining
we
it
don't
well,
understand.
but you know what I'm saying. Like I think, and it is interesting. And I always ask, have you been on antibiotics before? And you often get a yes, right?
Yeah.
Patients have always, because most of these patients have had recurrent infections when they were young, and would say I was on multiple rounds of infections for ear infections, for throat infections. So they would be on antibiotics, and sometimes you have to make them. Try to. I'm afraid to put words in their mouth. So I sort of just ask, did you feel better?
Gotta be cautious about it.
Yeah, you have
That's
to be very careful
true.
about how you lead the witness. You're not allowed to do that in a court of law.
Right.
So I'm very careful about that with patients. I don't want to sort of give them what it is I'm looking for, because you don't want to be suggestible necessarily. But I think that those questions are important.
Right. So we're not going to have time to do this, but I don't want to leave out, since we're talking bacterial infections, the microbiome. Okay.
Yeah. Oh my God, the microbiome.
This, I guess, is a teaser. Okay.
It is a teaser.
Microbiome is so unbelievably important, both in its benefits and assets to us as human beings, in helping to keep us healthy, help our immune system to remain potent and healthy,
right,
and process food and process nutrients and make short-chain fatty acids and all this other stuff in the colon, but put them in the wrong place at the wrong time, or at the right time even, and you have a whole new problem. Same bugs, different location. So again, it's this idea that I love talking about, which is it's not just bad and it's not just good, and it's important to recognize all these.
And I think that's a very common question we get asked. How do I fix my microbiome? And the microbiome is so specific to so many different things. Like how you were born,
right?
Vaginal, cesarean, where you were born, how were you breastfed, were you bottle fed,
Right.
What were your early exposures, how many antibiotics had you been on early in life?
Infections did you have?
When did you start eating solid foods? Even there's some research that shows that can change your microbiome. So I think a healthy microbiome for person A is not necessarily the same for person B, and I try to explain that. But yet I do, we know to some extent what a healthy microbiome should contain, right? Because a lot of the metabolites that come out of a microbiome are very important for different physiologic functions, including neurotransmitter synthesis and degradation. So for the enzymes that are involved. So to some extent, there are certain species that should be part of the microbiome, and to what extent in terms of number of colonies, I'm certainly not an expert in that, but
just think about the numbers. I said earlier, 70% of our immune system resides in the gastrointestinal tract, and I had the number, I think I said 1 trillion bacteria live in our colon. There's more genetic material there. I think it's crazy. I don't know. I think it's 1,000-fold or many thousand-fold more genetic material.
Right.
And it's been that way for hundreds of millions of years. So it works. There's a reason that we live with bugs, and our immune system loves them. And if things get disturbed, if there's dysbiosis or a problem, you can begin to see why that might cause huge systemic downstream problems.
I think it's also an important point to say, as you started the conversation by talking about how we're basically full of bugs. So it's always interesting to me that sometimes it's not about the bad bugs, right, that cause disease, the pathogenic bugs, but the altered ratio of even the good ones that can cause disease, right? So that I think that's so interesting to me.
That's actually one of my problems using the term dysbiosis, although it's a more scientific term.
Yeah.
I don't actually believe small intestine bacterial overgrowth is dysbiosis. It's just they're in the wrong place.
Right.
They're the same damn bugs that live in your colon. They just swam upstream to get the food in your small intestine. But they don't belong there. We didn't evolve with them there.
And our standard American diet doesn't help things.
No. I don't know if we want to get into that.
Well, I mean, it's an important part of health. As much as we talk about all these very...
No, I want to, but I'm not sure in this episode.
Oh.
We can. That's fine. No, it's hugely important.
It is hugely important. Yeah. I mean, I think, first of all, the food itself contains bacterium.
Right, which is probably good.
Which is probably good. But it also creates lots of inflammation along the gastrointestinal tract and, not enough fiber, so poor motility, and that creates more stagnation, which creates more dysbiosis.
And more SIBO.
And more
motility
SIBO.
is the father or the mother of SIBO. Let's face it.
And then we talk about the enteric nervous system and how it interacts with the immune system and the central and the peripheral nervous systems. And then you've got a mess on your hands.
Right. So we probably only have a minute or two left. But the other aspect of bacterial infection, which we hinted at a little bit, is its role in leading to the development of autoimmune disease.
Yeah.
Okay. So it's this whole concept of molecular mimicry, which I think is an enormously important topic, specifically to our septat patients. Not everybody's going to agree with me, but I think that that's part of what's going on in so many of the inflammatory arthritis type complaints that our patients have, probably somewhat related to mast cell and POTS, where the body makes antibodies to fight off this infection, and those antibodies make a mistake in quotes and go after part of the person because of there's a similar antigen or markers on human cells, and I think that's just a major driver of autoimmune disease.
I agree with that. I think that's fairly well accepted, molecular mimicry as a topic.
Right.
But I think how it's applied can be controversial, right?
Sure.
But I do think it's very important. And I think that that's sort of, genius of these bacterium and these viruses, right? To have like pieces that look like ourselves. And so the immune system gets confused.
Yep. Evolution.
Evolution.
Telling you.
Evolution's a bitch.
Yeah. Well, it's also good. Good old Darwin,
I know. Thank goodness for
Darwin. All right.
I think that we finished our overall view of bacterium and bacterial infections. And this was fun, actually. I always learn a lot from you when we talk about infections.
Me too. Are you kidding?
Well, no, but I don't know infections like you do.
Yeah, but you're bringing a neuro perspective to it. So
I should say my perspective. I don't know if it's every neurologist's perspective.
So I'm sure we'll come back to this.
Because we want to cover specific
tick-borne infections and stuff like that.
We'll have a topic on tick-borne infections for sure. And then next topic we'll discuss in the next episode is viruses.
Right. Okay. Well, thank you.
Thank you for joining us.
Bye.